Oh, beautiful. Okay. So as all of you know, because you're in this room, there are different versions of Castleman's disease. And when we first started these patient and loved one summits, everybody was in one big room. And that was difficult because of the heterogeneity of the disease, because there were people who had unicentric Castleman's disease all the way to patients with IMCD and TAFRO in the same room, okay? And there are commonalities among all of these patients, but there are some specific things to each subtype. So I'm really glad that we have an opportunity to talk a little bit about this subtype and some of the overlaps that happen with the other diseases. In fact, we have a new room this year, which is the oligocentric Castleman's disease, and that was developed by work done here through the registry, because we found that there are some people who don't fit either unicentric or multicentric Castleman's. Okay. All right. So our overview today, this talk is fairly similar to last year because not a lot has changed. We're going to talk about treatment and symptom management, some research updates, and then give you some time for questions. Okay. So what is unicentric Castleman's? So I tell my patients with Castleman's disease that they are the pink zebra with purple stripes, okay? Not only are they a zebra, but they're a little bit more unusual than the typical zebra. We still hear hoofbeats, but their disease doesn't follow typical patterns for what we would consider cancer, nor autoimmune disease, nor an infectious disease. It is something amorphous that we're still trying to figure out. What we do know about what is called unicentric Castleman's disease is that there is a single region of enlarged lymph nodes, okay? So how do we define these regions? Well, that comes from lymphoma, all right? So the treatment of lymphoma developed through radiation oncology, and they would define what a single region was based on what was encompassed in a radiation field, okay? So the different regions of the body are named based on those radiation fields. So the anterior and posterior cervical nodes, the mediastinal nodes, the mesenteric ones, the inguinal ones, these are all regions where lymph nodes can enlarge and can be encompassed by radiation. So when someone presents with a lymph node that is just not going away or is identified serendipitously on a CT scan, the concern is that this is a cancer, okay? So people undergo biopsy or excision of that lymph node, okay? And sometimes that comes back with Castleman's-like features under the microscope, okay? And it is a diagnosis of exclusion because everything else has to be ruled out. You cannot have a solid tumor. You cannot have lymphoma. You cannot have a histiocytic disorder. You cannot have a plasmacytoma. It has to look only like Castleman's and nothing else. And they also have to rule out any other reason why they might have a reactive lymph node, because a reactive lymph node can have Castleman-like features. And that's why it becomes very difficult when it comes back to the patient and their doctor, because they're like, what's this? All right. Most of the time, patients are asymptomatic. But what we know about the Castleman's-like pathology is that it is driven frequently by a cytokine that is called IL-6, okay? And IL-6 produces symptoms for the patient and can help promote the growth of these Castleman-like lymph nodes. So while some patients can have a Castleman's lymph node and be completely asymptomatic, you have other patients who have this Castleman's-like pathology but have cytokines even after the lymph node has been removed. It's rare. It's considered an orphan disease. There are about 5,000 cases annually in the United States. The majority are not reporting themselves to us in the registry. But the good news is that most patients with unicentric Castleman's disease do very, very well. Okay. So we're trying to learn more. So this is a paper that was published in Blood Advances that combined all of the information that we have from the registry, as well as our clinical experience at a variety of centers of excellence for Castleman's, which includes here, the University of Arkansas, the Cleveland Clinic, and a few other places around the country. All right. Why do patients with unicentric Castleman's disease feel bad? Okay. First, the node can get big enough to push on adjacent structures. All right. So if you have a lymph node in your neck, is it pushing on your trachea? Is the lymph node on your neck pushing on structures that come out of your spine? Is the lymph node in your groin causing edema in your leg? These are all compressive symptoms. Patients can also have inflammatory symptoms. They may have fevers, probably not high, but low-grade fevers that they have almost every day, 99 to 100, where they can't really say that they have an infection, but they just don't feel good. They may have rashes. They may have other inflammatory symptoms where they just don't feel right. Some patients can also have secondary autoimmune phenomena. And these are the two that we have noted in the registry. One is called paraneoplastic pemphigus. These are rashes that look like hives over regions of the skin as well as the mucosa. And then bronchiolitis obliterans, which is an inflammatory condition in the lung. And usually this is picked up when patients present with shortness of breath and we see changes in the lung that are consistent with an immune attack on the lung. And very, very rarely, the unicentric Castleman's is a harbinger for a malignant transformation. So you may have somebody with Castleman's that then develops a lymphoma or develops a multiple myeloma. So that's why once a patient comes to me with unicentric Castleman's, I tell them I own them forever. Because I really want to find out how they're going to do over time and what is the natural history of their disease. And that could be as simple as I see you once a year and you're doing fine and you show me baby pictures or wedding pictures and then you go on your merry way. But other patients need to be followed more closely because they're having symptoms that go beyond their original diagnosis. All right, the first line of therapy is to get rid of the lymph node that you've identified, okay? So if you can get a total resection, that is the ideal world. So that's really in the hands of the surgeon, right? So you're gonna go to the surgeon and they're gonna say, I can take it all out. Now, between you and me, every surgeon thinks they can take it all out. But if they can take it all out, that's the ideal world, all right? And it's tricky because we're talking about lymphoid tissue. So that may require just a little bit more than they would do for, say, a solid tumor, because they have to go into the margins to make sure that they get all of the cells that are in the capsulated region as well as a little bit beyond. So if you are resectable, meaning the mass is in an area that can be accessed and can be removed without toxicity or morbidity for you, then resection is the answer. And most of the people who can get completely resected don't have symptoms after that resection. And some people who had symptoms prior to resection will have resolution of symptoms once the mass is out, okay? Excuse me, the problem comes when the disease is not resectable. And that is all about real estate, okay? If you have an area that's in your chest and there are structures in the way of the surgeon being able to get a complete resection, part of that mass may remain. Or if you have a mass in the abdomen that is really deep, it may be difficult for the surgeon to reach it without adversely affecting other organs. And so they're going to say, look, we can't get it out. We're going to have to monitor this. And so that is one of the discussions after you evaluate whether it's resectable or not, about what you do with that mass that remains. Ideally, you get it all out, but in some cases, if you're having compressive symptoms and they can't get it all out, even a partial resection will help because it can reduce the compressive symptoms that you see. Okay. So after surgery, yippee, you're done, right? 90% do very, very well. And there's no formal guidelines about how much you should be followed by, monitoring. But I like to see people once a year. Just check their labs, make sure they're doing okay. And sometimes I'll do scans if something is puzzling me about how their disease is behaving. And that can be dependent upon like where it was located. Some patients have symptoms that persist even after complete surgical excision, or what they think is complete surgical excision, because our scanning is not 100%. Okay, so if you have a CT scan or a PET scan that shows complete remission, that doesn't say there aren't cells that are on the periphery that we're just not picking up because the volume of disease is not high enough for us to see. So it's not the end of the journey. What symptoms do people have after surgery? Well, if we take a survey of our patients, this is what they can see. Like 78% of patients will have some symptom, right? That could be fatigue. That could be other lymph nodes that come and go. That could be pain at the site of the surgery. That could be night sweats. So it's very heterogeneous, and every single patient is a little bit different. So our approach is to first rule out alternative causes of the symptoms. Make sure that there's not an infection. Make sure that there's not some other process going on. Make sure that there isn't an autoimmune disease. And then if the symptoms are still there and we haven't found another cause, then we need to go to IMCD type therapies. And that is helped if we can see that the inflammatory markers are up. And that can include looking at things like CRP, which is a C-reactive protein, the ESR, VEGF levels. All of these levels are labs that your Castleman's doctor should be following if you're having inflammatory symptoms and we can't figure out why. Okay, so these are the symptoms that you should be talking to about with your physician. So night sweats, these low-grade fevers, inability to eat, weight loss, or sometimes weight gain, pain, and then skin lesions. In particular, we should watch for those paraneoplastic pemphigus lesions, which are like hives, or angiomata. So angioma are little red patches that are collections of blood vessels under your skin, and patients with Castleman's can develop them particularly on their torso, chest, and back. And then I always talk about the 3 Ps. Is a symptom puzzling? Is a symptom persistent? And is it progressive? So if you get an itch on your nose, it's gone in a day, I don't need to hear about it. But if that itch on your nose is persisting for 3 weeks, I need to know. So that's a lot of the active observation for a UCD patient involves being active about understanding what's going on with you. And frankly, you have to be an advocate for yourself because it's so rare that a physician sees this and understands that what you're experiencing is quote unquote not in your head. So what are the strategies if it's unresectable? Okay, so if it's not resectable, first you need to evaluate, is this asymptomatic? So just because you have an enlarged lymph node, if it's not bothering you, you're not going to do anything about it. You're going to follow it, okay? Because the toxicity of doing something about it is worse than an asymptomatic lymph node. However, if you're having symptoms, then you need to think about what symptom is being produced. Is it compression? If it's compression, then you're going to try to decrease the compression, all right? And that's when I use rituximab. So rituximab and steroids together don't treat Castleman's pathology, right? It's not eliminating the mysterious cell that's producing Castleman's, but it will reduce the inflammatory cells around the Castleman's pathology. So if you're having a lot of compression, decreasing that inflammation can decrease the size of the lymph node and the compression improves. If it's only inflammation, what does that mean? If it's fevers and sweats and anorexia and general fatigue, then you need to reach for the anti-IL-6 antibodies like ciltuximab or tocilizumab. Now, if you get beyond that and you're doing the therapy and the lesion suddenly becomes resectable, you send them back to the surgeon, okay? Because getting it out will eliminate the nidus, the reason that you're having the symptoms. If it's still not resectable, then you need to evaluate if you can observe or if they need radiation, okay? Radiation would be used sparingly and in low dose in those areas where it's safe to do so without impacting the patient in an overall setting. Okay, so what are some treatment side effects? Okay, how many in the room have received rituximab? Yep. So you know, it produces infusion reactions, right? It can cause fevers, rashes, hives during the time that you're getting the infusion. It does lower your immunity by decreasing antibody levels from normal B cells. So you have to be careful about upper respiratory infections, and you have to be careful about viral infections, in particular shingles. So the advantage to rituximab is that it's a course. You would give between 4 and 8 cycles or doses, and then evaluate whether it's doing what you need it to do. In contrast, the anti-IL-6 antibodies like ciltuximab and tocilizumab can also produce infusion reactions, but they have a few more side effects that are related to affecting IL-6, which include increasing cholesterol, abnormal liver function tests, dropping blood counts like your platelets, and the risk of infection. You are immunosuppressed when you're on these agents, so you do have to be careful. And sometimes it can come on suddenly. Steroids, how many have had steroids in the room? Oh, that was you. I guess I've done everything. So steroids can produce steroid side effects, which can include weight gain, elevated blood sugars, moon face, irritability, swelling, and stomach irritation. So while it may give you a real boost of energy while you're on it, no physician wants you on it for very long, and you need to taper off of it pretty quickly. Radiation therapy the side effects of radiation therapy depend upon where the mass is being radiated, okay? So it all depends on what is in the same region as the area of your Castleman's. So if it's in your neck, the region may affect the blood vessels in your neck. It can also affect your thyroid. It may affect your jaw and your teeth, okay? If you're getting it in your abdomen, the organs that are in the pathway of the radiation can be affected. So these are all reasons why you have to carefully weigh the risks and benefits of these therapies. 2 other therapies we've used in patients with UCD who are having inflammatory symptoms include sirolimus and cyclosporin, and these are both immunosuppressive agents that affect T cell function. So you can have abnormalities of blood tests, including your cholesterol and your liver functions, as well as the development of oral ulcers as a result of the immunosuppression. Okay. So based on the Accelerate data, we now know that there's another group of patients who have what's called oligocentric Castleman's disease. These patients used to be lumped in with unicentric in that they may have a cluster of lymph nodes over a larger region, but not over their whole body. And for these patients, the therapy can't always be resection like unicentric patients have. And so more of what we talked about in terms of dealing with inflammation and compression have to apply. And now we also know that multicentric Castleman's disease is a multitude of disorders, which can include those that are virally induced by HHV and those that are more similar to multiple myeloma, like POEMS. And then within standard IMCD, there are multiple entities as well. So we're learning, and we're learning from you all because you guys are in the Accelerate database. Okay. So what can I do after getting a UCD diagnosis? All right. Locate somebody who actually knows something about it. There are centers of excellence, and on the CDCN website, you can find the place that's closest to you. We are working to try to expand our reach with things like telemedicine. So Dr. Brandstatter in particular may be trying to provide more regional expertise to patients who can't travel here to us. Learn about Castleman's disease in your particular subtype. That's what you guys are doing today. There are also resources online like the CDCN. Be careful about chat rooms because sometimes people don't know what their diagnosis is or how to describe it, and they may not have a physician who knows about the disease. And so it can be a good lead up to where you need to go. You might get suggestions about who you need to see, but remember that that information is not vetted. And so you want to make sure that you confirm everything that you're being told. Okay. Monitor your symptoms like we discussed, and talk to your doctor about them. A lot of my patients keep a notebook. And if something new or different comes up, they write it down. And so that way they know what is new, what is different, what is puzzling, what's persistent. And keep track of critical lab values. What is your hemoglobin? Are you iron deficient? Do you need nutrition that might help your blood counts improve? What are your inflammatory markers? Do you need to keep a spreadsheet and graph? No. But it's a good idea to follow what your numbers are doing so that you have an idea of what might be coming, because sometimes the numbers on your blood tests can be ahead of how your symptoms are progressing. So what is important about monitoring lab markers? They're an objective measurement of the disease, because so many of my patients have fatigue. How do you quantify fatigue? Is it the fatigue of a mom dealing with an infant or someone who's working a 80-hour job? What is that fatigue, and how is it expressed in what you're doing every day? Is it fatigue that doesn't let you get out of bed? So it's really hard to find an objective measurement for that. So we're using the objective measurements of the lab studies to provide correlations to the symptoms that you may be having. And they can also help us select which therapy. So if your IL-6 numbers are really high and you haven't received an anti-IL-6 therapy, following that IL-6 level will tell us when to pull the trigger. Okay. So these are the laboratory markers that I watch regularly. So your hemoglobin, your platelet count, your C-reactive protein, your ESR, and your kidney function. All right. Most UCD patients return to a normal lifestyle, which is great. But then that leaves the patients who don't. But trying to maintain a healthy diet and some mindfulness about your disease and trying to get exercise in your life to try to control those factors that you can control can really help manage the disease, because it is a chronic one. And it's super hard when you're tired, right? Like, Dr. Nasta, I really do not feel like doing yoga. It's just not going to happen for me. Fine, that's good. But can you go for a walk? Like, can you leave work at lunchtime, take a deep breath, and go outside, touch grass? Because that may help you. We already talked about diet and exercise. Is there an anti-inflammatory diet? Probably not. But a good plant-based diet that is moderate across all of the elements that you need in the course of a day would be advised. And then exercise. It's surprising the data shows that exercise helps with fatigue. This comes from the cancer literature, in that patients undergoing chemotherapy who exercise do better than the patients who don't, even if they start off sedentary in both populations. And then seek support. It's really hard. And it's hard not to be anxious about this disease because you're living with it and it's affecting all aspects of your life, how you get to work, your interactions with your family. I had one patient who desperately wanted to go to her son's baseball games. Like all she wanted to do was to feel well enough after work to go sit on the bleachers and watch her son play baseball. And so her goal was not, I'm going to get rid of this. It's, I want to be able to go to that baseball game. So our therapies and timing of our therapies were such that she was well enough to do that. All right. So what's in the research pipeline? We now know that there's a trafficking of white blood cells in and out of our lymph nodes, okay? And that directs how they interact with each other. Now, lymph nodes are special collections of cells. They are there to help us develop these cells called lymphocytes that help us respond to the environment, okay? So there's constant traffic in. There are new cells that are being made in the bone marrow. There are cells that are there to show you what infection you've had recently. There are cells that are in the process of being eliminated, as well as cells that are being kept alive by autoimmune processes. The research in unicentric Castleman disease has focused on the cells that are coming into these lymph nodes, but also the cells that are kind of supporting them. It is these stromal cells that we think may be a key to figuring out why patients with Castleman's disease develop the pathology that they do. So Dr. Brandstatter has been collecting these lymph nodes. Whenever you guys call and say, hey, I have a new diagnosis of unicentric Castleman's, what should I do? He'll be on the phone with you instantly saying, I need your lymph node. So he'll talk to your surgeons about getting that sample in order to do better scientific evaluation of these cells that are all around. The stromal cells of unicentric Castleman's disease are different. What we don't know is the chicken and the egg. Are they abnormal because something about the Castleman's makes them abnormal, or are they abnormal and that is producing the Castleman's pathology? And so our research is trying to figure that out. What we know is that some of these cells have this hyaline vascular pathology or histology. What that means is it looks like an onion. Like if you cut an onion on its side, there's this onion skinning pattern to them. But the white blood cells in that sample are polyclonal. They come from all different places, right? So what if the stromal cells are the ones that are clonal? What if they're the ones that are having an abnormal pathology that are drawing all these abnormal white blood cells into the lymph node? So if they're abnormal, they're going to direct those white blood cells to behave differently. They can accumulate when they're supposed to disseminate. They can produce abnormal inflammation. And so understanding that will help us find new ways to identify the unicentric Castleman's patient that will be totally fine after resection and those who may need a little bit more. And it might help us to more quickly assess those patients for therapies. And so we're trying to identify these different populations. And so all of the biobanking that's been done with the lymph nodes in Accelerate and here at Penn shows that there's this one population that seems to be expanded. And we're actively testing whether or not we can grow them and if that's a clonal process. What do we mean by clonal? Is it coming from a single cell? Did one cell go rogue? And that's why we have this problem. And so these are all the studies that Josh has done since like 2020 to identify this population. All right. He has found this mutation, the PDGFR beta, in about 15 to 20% of patients with UCD. And it's inside the stromal cells. And what's great about that is we know that this particular mutation can be targeted with medications that affect what's called a tyrosine kinase. So our newer trials that are being applied in multicentric Castlemans may also be able to be applied for patients with unicentric Castlemans that have ongoing inflammatory symptoms. All right. And he tested this in other cell populations, and if you have this mutation, the cells grow abnormally. And you can affect them by these medications that are the tyrosine kinase inhibitors by targeting this particular gene mutation. All right. So we still don't have answers to all the questions. So all of this is going to require ongoing work, and hopefully we'll have the funding to do it. But we'll be looking at the stromal cells that have this gene mutation. Why do they get the mutation? And then does having the mutation cause UCD? You're like, how are we going to prove that? Well, if you put the mutation into mice, do they develop lymph nodes that are like Castleman's disease? And so that process is underway. And then once we identify sufficient numbers of patients with this mutation, potentially they would be able to get this therapy. So I know that we don't have all the answers. We have some, and we're still trying to treat patients as best we can with the knowledge that we have. But I do think that there are newer treatment options, and particularly for patients with bulky and unresectable disease. In fact, we've been working with our radiation oncologists here at Penn in the lymphoma group so that patients with Castleman's disease can have a different plan for radiation and potentially use proton therapy in contrast to regular radiation, if that becomes our route, as well as some of these newer drugs that we might do. All right. So we need your help. If you know of anybody, you guys get called because, you're at the front line. You have a diagnosis. If someone calls you and said, I've been diagnosed with this, what do I do? Where do I go? Please put them in contact with CDCN. Get them to a center of excellence so that we can learn and we can help them sooner. All right. Questions?
So we were talking about the lymph nodes and how they want to get out. Well, I had a lymph node that was concerning, and at the time I had the MRI, and they said one of the radiologists knew a suspicion of Castleman. So when I went with that, I had said to my general surgeon, let's biopsy it. They did, but nothing came back as Castleman's or anything. So, but it was getting bigger, and where it was in my groin, it hurt. So I heard you say that if they get it all out, well, my surgeon took out what was there, but how do I know that if that was all of what it was there, So
it's hard. It is very difficult to know if it is entirely removed. Okay. And so that's why I always give the caveat that complete resection may not be complete. And you have to follow that bed for some time to see if another lymph node comes up underneath, because sometimes it can be a cluster of lymph nodes where one is the primary and there's smaller ones underneath that look normal but are actually the pathology. And that's why getting the surgery at a place where you have a surgical oncologist who's worked with one of us before, because they'll know, okay, I'm not just going to take out one lymph node. I'm going to take out a group of lymph nodes in that area. It is a little bit more of a complicated surgery and does produce more in the way of secondary issues like lymphedema. But if resection is the answer, trying to get as many of the associated lymph nodes in that area is pretty critical.
They took it out, and the surgeon took it out. She's like, they sent it off, and it was Castleman, because they took the whole thing. But I also, they kept me overnight because they hit an artery, so I kind of bled a little bit. But I still I did see a oncologist surgeon that knows about Castleman's, and they thought I had another lymph node, but I didn't. It was prior to surgery, but I know that I'm still having trouble in that area. My groin still bothers me. I don't feel any nodules right now. I don't feel any, I don't feel it right now. But I do have other issues that's been going on, and my oncologist, she somewhat knows what's happening. I mean, and I was looking at some of the blood work that has caught my eye that is actually being elevated now. So like it's not before, but now I'm having these other things that's going on. So.
Yeah. So like I said, like you can have a complete resection, and because we don't know what is that one cell that is producing Castleman's, we're looking for it, I promise. Until we know what that cell is, it's really difficult to say we've gotten it all.
And also my surgeon, she just took out what was bothering me. It wasn't that she was looking for Castleman's, because she had no idea what she just said, I'm taking this out, you have a 3-inch nodule, that's pretty good size, or 3 centimeter, I think it was a pretty good size. And so she took it out, sent it off, and you'll have to find someone else. So they sent me to, I've been to 2 oncologists, so I'm kind of at one that knows a little more about the Castleman. So, but I feel like I know that she would look in more to it if need to be. So
yeah, I mean, so it's a matter of doing the imaging to make sure that there aren't still lymph nodes in that area or soft tissue that would be of concern, and following that. But if they can't find anything, then trying to treat the inflammatory symptoms around it, like we discussed, may be the route that you go. And it's complicated because if they're not used to treating Castleman's, they're like, well, what am I going to follow if I give you this drug? And it is hard. You follow the inflammatory markers, you follow the symptoms, and the drugs that are approved for Castleman's disease are based on an improvement of symptoms. So it can be
already taken out the lymph nodes. So even before, I didn't know that I even had. So they just took out a lymph node. They didn't know what it was from or whatever. So
right.
That's the thing is.
Yeah. So following along, doing more complete staging, making sure that there isn't another area that is inflamed or involved.
I'm pretty sure there's a couple more areas. Plus, when my markers my blood counts are elevated, I have to have more blood work done Monday. So other things that's going on too. And I don't know, it could be Castleman's and it could be something else that's
right.
Like David was saying today, things can play a part in one thing.
Absolutely. I think someone over here had a question first.
Okay, I just had a question in terms of what research is find is most promising now in terms of either diagnosis or treatment.
The research and diagnostics is trying to narrow down the pathology, so trying to find that cell of interest. So perhaps this stromal cell research will pinpoint the cell of interest. And then from a therapeutic standpoint, we're approaching the inflammation from known pathways inside cells that produce inflammation. So there's a pathway that we've identified in idiopathic multicentric Castleman's that involves the JAK-STAT pathway. So the 2 trials that we've opened, the sirolimus trial that we did first and the ruxolitinib trial, which is opening Monday, it targets those pathways. So that's where we're going therapeutically. But there's a whole range of stuff in between because we still don't know what is the cell that causes this. And we also don't know what is the trigger that makes that cell behave abnormally.
Is it possible, so I have new lymph nodes, they're large but still small. Had a PET scan, didn't light up. Does that mean they're never going to light up, or is it just maybe too soon?
Depends on size. Remember that the uptake of sugar by a PET scan requires a certain volume of uptake.
Okay.
And it may not be that they are not taking up sugar, but they're not taking up sugar at a level that's higher than your liver or your mediastinum.
Gotcha, okay.
So, but just because it doesn't light up on a PET scan doesn't mean that it's not abnormal.
Fair enough, okay. Yeah, I've got all my symptoms back, so I'm assuming, but
Right.
yeah, okay.
Yeah, I would be led by your symptoms and your inflammatory markers
Okay,
in terms of evaluating what those lymph nodes are.
okay.
I'm kind of wondering, I'll try not to keep this too personal, but UCD excised about 7 years ago, fine, no symptoms, but within the last 2 years, Graves' disease, thyroid eye disease, Addison's, and yeah. But I'm wondering if the UCD needs to be revisited, or if there's other. I'm being treated clinically at Mayo for all of this, and did a drug study and non-responsive to that, but we're kind of at a decision point. I guess at that point I'm wondering if UCD should be revisited, or if.
Yeah, potentially. I mean, that's the thing. What we don't know about the natural history of every patient with UCD is whether they stay UCD, do they become IMCD? The data up to this point shows that UCD patients don't, but we don't have hundreds of thousands of patients. We have a very small number. So if anyone tells me, oh, that never happens in Castleman's disease, I'm like, well, just wait, because I will find a patient in which it happens. So yes, it should be revisited. Just thinking about making sure that, is it still a single site that was the problem? Do you have other lymphadenopathy? Are there other signs of disease that run with UCD?
How about that genetics that you're talking about, that gene?
Mm-hmm.
Is it something now, like, I mean, I'm trying to think, like, my daughter has UCD, she just had we found out 2 years ago when she had a humongous lump in the middle of her abdomen.
Mm-hmm.
But is that genetics test something that can be used right now for, like?
Yeah, you can do it on the old pathology. So we actually have paraffin embedded samples that we can test for this now. So
somebody can be tested and you have that gene.
You can test for that in the sample. Remember that it's only about 15 to 20%. So even if it's not there, that doesn't mean that you don't have issues with UCD. It's just, if you can identify it, it gives you a target.
Then another question is, for the lymph nodes, the doctor was saying, it doesn't matter if it's PET scan or a regular scan. What do you think?
Where I use a PET scan is if I'm thinking that there might be something else. I don't need a PET scan because, as you can see, PET scans can have variable uptake and then the lymph nodes can still be abnormal. What I use it for is like, well, these were not having any FDG uptake and then all of a sudden they are, and that means that something may have changed.
There aren't any questions in the chat. They just wanted me to pass on their thankfulness to you and the rest of the team.
Oh, well, thank you. All right, well, great. I'm around. I'll also be in the panel session if you guys have questions that you didn't want to talk about here. And we're happy to see you. Hopefully we'll keep learning. And thank you so much for your support of CDCN.